Welcome, I'm so glad you all could join me. I'm Chavah and you're watching Ask a Midwife.
Hi everyone, this is Chavah Ben Sion. Thanks so much for tuning in. This is the Ask a Midwife channel. In my last video we talked a little bit about the two different categories of inductions and what's the difference between a medical induction and an elective induction. In this video I want to cover a little bit about how an induction is performed and what are some of the different ways that a medical induction would be performed, and also hopefully we'll have time to talk a little bit about the more natural methods of induction. So we all understand that the cervix is the opening of the uterus and it needs to open up in order to let the baby come down and out. And the contractions, which is basically the uterine muscle fibers, they squeeze together to push the baby down into the pelvis and open up the lower uterine segment, the lower portion of the uterus, and that's called dilation, to allow the baby to come down and out. So basically, the first step in an induction is, and the first step in any labor really, is that the cervix, that opening of the uterus, needs to become soft and pliable. If it's hard and firm, a lot of contractions won't open it. It first needs to become soft. So sometimes they'll put a suppository, which is basically like a little amount of a medicine, and they insert it up into the vagina of something called cervidil. It's also called, the generic name would be prostaglandins. It's a prostaglandin suppository or a prostaglandin insert, and they basically put it up inside the vagina, and it sits there and releases those prostaglandin hormones up near the cervix, and sometimes ideally that softens the cervix, and it can also cause contractions. There are cases where the woman has entered the labor process with just the use of the prostaglandin insert and without any pitocin. Okay, but generally what happens is they put it in, they leave it in overnight or for a certain amount of hours until it either comes out on its own or another decision is made about what to do next. So sometimes it comes out, and sometimes it just results in labor, and sometimes it doesn't result in labor. And so what they'll do usually is they'll follow up the prostaglandin insert once the cervix is examined, and it's soft, it's thin, it's pliable, it's inducible. Okay, so if a woman has an inducible cervix, that usually means that her cervix is soft and ripe. So then they will usually start a course of pitocin, which is the synthetic version of the woman's own oxytocin, which is actually, it's a synthetic version of an important hormone, but it's not the same thing. The naturally occurring oxytocin is otherwise known as the love hormone. It's the hormone that our bodies release when we breastfeed, when we feel love, when we feel happiness, when we feel joy. It's also it's arousal, the hormone that our bodies release when we are aroused or we have an orgasm. And it's also the hormone that is responsible for our contractions. It contracts the smooth muscles. So whether it's the uterus, so the body knows how to target, depending on what's needed at that time. The body creates receptors. So in the pregnancy, the body actually manufactures or creates receptors in the uterus so that when the oxytocin is produced, it targets the uterus. Okay, and that's why a woman can be breastfeeding in an early part of pregnancy, and it doesn't necessarily make her have her baby because her receptors are not, there's not a whole lot of receptors for her uterus at that time. The receptors are more for her breastfeeding and so on. So that's a really interesting part of how oxytocin works. But pitocin is the synthetic version, and that's why sometimes when a woman is given synthetic pitocin, or synthetic oxytocin rather, pitocin, and it doesn't work, it's because her uterine receptors aren't abundant. Okay, so it's an interesting fact of, well, you think, well, we're giving her this hormone, why isn't it working? It's because she doesn't have the receptors. Okay, so Pitocin is usually given with an IV. It's given intravenously. It's given on a very controlled amount. So they start at a very low amount and they usually increase it every 15 to 20 minutes in a hospital setting. The woman is on the monitor. The baby is being monitored for heart rate and the uterus is being monitored for contraction patterns. So they want to see that the uterus is contracting no more and no less than 3 times in a 10-minute period, and they usually keep raising the rate of the pitocin until the contraction pattern is matches that 3 times in 10 minutes. And they also want to see that the baby's heart rate stays at the desired rate during those contractions, because sometimes the baby can feel distressed in a result of those contractions. A lot of times we don't really I don't think a lot of people really consider it, but when the woman's own body begins labor on its own, it's usually because everything is ready. So the baby's in a good position, hopefully, ideally. The baby's body actually releases some of the hormonal cocktail which starts labor. The mother is ready, the cervix is usually ready. That's in an ideal situation, but more so with that situation than an induction, that the body isn't really ready. So what happens is sometimes the baby goes into distress more than if it were a natural labor, because the contractions are quite strong and it's like sudden, rather than the baby doesn't really know what's coming. So so generally that's usually results in labor, but it also usually results in a more painful labor and harder to manage, because the woman is stuck to the bed and she isn't able to move around freely, and she isn't able to use mobility and freedom of movement to cope with her contractions, which is why a lot of reasons why women often get an epidural when they're on pitocin. But I have a lot of clients who have needed it. I don't have a lot of clients who have needed an induction, but there are a lot of clients who I have helped who have needed an induction who have successfully done it without any pain medication. They've used the things that we can do while attached to the monitor and the IV. Because the woman stays attached to the IV, she stays attached to the monitor, and that way we know whether or not the baby's tolerating the contractions. And if the baby isn't tolerating the contractions well, they usually turn down or off the pitocin, and then we reassess what's happening with the baby. I wanted to cover one additional induction technique, and that's called the balloon or foley catheter. Basically, a little catheter is inserted into the cervix and inflated with a little bit of sterile water, so that it actually acts as a balloon. And that balloon puts pressure on the inside of the cervix, and it sort of forces it open like a little wedge. And it can be really uncomfortable for the woman, kind of crampy, might have a little bit of spotting. They do this in the hospital, so she'll come in, usually in the evening. They'll put in the balloon and she'll feel some cramping, she'll feel some discomfort, and there may or may not result, contractions may or may not be the result of that, but in general that's a way that they use as an alternative to cervidil, or the prostaglandin gel that we talked about. And that is another alternative to ripening the cervix and to creating a more favorable situation for the cervix to be induced and for contractions to actually affect the cervix. So I personally have experience with all these methods that I've discussed, and there are appropriate methods for each situation in terms of the cervix, if it's not ripe, if it's not short, if it's not effaced, thinned out. These are all terms for ripening, basically, that she really does need some ripening. So whether or not it's pharmaceutical like cervidil, or mechanical like the foley catheter, either one of those methods might be employed to soften the cervix. And sometimes it can result in labor, where the woman doesn't need to go on to have pitocin. Usually the body takes over, and sometimes the woman does need pitocin after. And like we were discussing recently, sometimes the cervidil and the balloon won't result in the desired effect, and then the woman should be given a choice. If her baby looks good on the monitor and her vital signs are okay, she should be given the option to wait 24 to 48 hours and try again. Breaking the water is not in my personal opinion and my experience as a midwife of over 20 years, breaking the water as a method of induction is not a good idea. There are a few reasons. Number one is once you break the water, you've got a pathway, a potential pathway of bacteria or organisms, whether it be group B strep from the vagina, if she has group B strep in there, or just any bacteria. There's a pathway up into the uterus, which is not ideal. Also, there's a higher risk of cord prolapse, a higher risk of issues with the cord, and it doesn't always work. So basically, then you've got a ruptured bag of water, and you don't have labor. So then you still need to resort to the other things, which prolong the labor and prolong the exposure of the baby. And also, once the water's broken, the baby can't always rotate in the way that he or she needs to, and so you end up basically trapping the baby in a position that's not always ideal. So let's say that whereas the cushion of water provided ability for the baby to turn his head and tuck his head a little bit better, or to bring his arm down, or just to make a turn inside the uterus and inside the pelvis, the water is now, think of the difference between being in a pool and being shrink wrapped. So once the water is removed, once the water is let out, the baby is more shrink wrapped, and it's harder for the baby to move and maneuver. So it's really not ideal, and you get a lot more fetal distress when you break the water. Now, if the woman, if her cervix is already, fully effaced, fully thinned out and soft, and she's already, 4 centimeters open, and the baby is the head is well applied to the cervix, there's a chance that having the water broken might work better and be a little bit more gentle than doing, pitocin. But I'll leave that up to the individual provider and having a clear, respectful discussion with the woman, with the client, who is, choosing what to do about that. But that's a situation that even though it is not uncommon, it's not really like the classic inductions experience. So, but it does happen. Okay, so I have a lot more to say, but I notice my battery is getting low, so I want to finish up by saying that next video we're going to be talking about natural methods of induction, and I know you are all very anxious to hear that, because that's one of the things that I get the most questions about is, okay, I don't want an induction, I know that. There's enough information out there to tell us, like, okay, that's maybe not ideal, especially because it's not a medically necessary induction, but what I do want is to encourage things. And so we're going to talk about why we would encourage things and how we can encourage things in a way that's not harmful to our body and that actually increases our chances of having a normal, natural, healthy childbirth process. All right, thanks so much. I'll see you next time. Bye.